Okay, welcome everyone to the March 5th, First Friday Addiction Toxicology Case Conference. I'm Tim Wiegand. Next slide. This is brought to you through a collaboration from the American College of Medical Toxicology and the American Society of Addiction Medicine. This webinar series is recorded and will be available on both websites after the recording in short order. Next slide. We have prior addiction medicine, addiction toxicology case discussions recorded, as well as FAQs embedded on the ACMT website page. So if you're interested in prior recordings and FAQs for 6 of these webinars, please see the links embedded on the ACMT website. Next slide. I'm Tim Wiegand, the Director of Addiction Toxicology and Associate Professor of Emergency Medicine at the University of Rochester Medical Center. And my co-moderator is Dr. Gloria Bashevitz, Medical Director of Strong Recovery and Professor of Clinical Psychiatry at the Department of Psychiatry, University of Rochester Medical Center, Rochester, New York. Next slide. And we have some distinguished panelists today. Dr. Kleinschmidt had emergency. He's in Texas, unfortunately, with some of the flooding. His colleague, Nancy Anisco, Dr. Nancy Anisco, is an assistant professor of emergency medicine and faculty in the Medical Toxicology Division at the University of Texas Southwestern Medical Center and co-director of the Perinatal Intervention Program, Parkland Hospital and Health System at Dallas. Dr. Neil Seligman joins us again. He's the Director of Labor and Delivery at Strong Memorial Hospital and Associate Professor, Division of Maternal Fetal Medicine, University of Rochester Medical Center, Rochester, New York. And Dr. Tricia Wright is an ACM expert. She's a professor in the Department of Obstetrics and Gynecology and Reproductive Sciences at the School of Medicine, my alma mater, the University of California, San Francisco, in San Francisco, California. Thank you all for joining us. Next slide. Just a quick announcement. The American College of Medical Toxicology is the virtual symposium, the 4th wave, methamphetamine and stimulants, that is available for registration, early bird discount through March 18th. If you're interested, please see the American College of Medical Toxicology website. This should be an outstanding virtual symposium. Next slide. None of our experts and panelists have any conflicts to disclose related to the material presented today. Next slide. And let's start with the first case, which is an interesting case of withdrawal in a newborn. Next slide. Case 1 involves a 29-year-old G2P1-2 female who delivers a 7-pound, 2.8-ounce baby boy at 38 weeks, 3 days. At 7 hours postpartum, the pediatrician noted mild hypoxemia with no respiratory depression after a meconium delivery. Noted in utero exposure to lamotrigine and venlafaxine. The exam was sleeping on warmer, respiratory rate 60, no retractions, responds normally to stimulation. APGARs were 1. At 1 minute and 5 minutes were 7 and 8. There was some suctioning of the meconium, but the baby seemed to be doing well. Next slide. At 33 hours, newborn is noticed to be jittery, have increased tone, is very spitty, and has 6 stools and 7 emesis. Scoring is 11 and 9 for neonatal abstinence syndrome. And that morning, the child is noted to be jittery and have the above findings: the jitteriness, increased tone, and is very spitty. Mother had been diagnosed with bipolar affective disorder and was taking a variety of medications, including venlafaxine, throughout pregnancy. She was also taking lamotrigine. There was no urine or meconium testing done. The NICU fellow advised that this SNRI, withdrawal from the venlafaxine, presents at day of life 2 or 3 and may improve within 24 hours, and advised close monitoring and no medication, but if in coordination, poor feeding, respiratory distress, and hypoxia, then transfer to a tertiary care center for medication. Next slide. Overnight, the baby has some feeding, but increasing jitteriness and tone. It's irritable and is more tachypnic. The NAS scores increase from 12 to 15 in the morning, and arrangements are made to transfer to the tertiary care center. Exam prior to transfer, the baby is 6% under its birth weight. On day of life 2, at transfer, the temperature is 37.7, heart rate's 45, sitting at about 140. Respiratory rate is 38 to 59. The exam is jittery when disturbed. There's mild jaundice, intermittent grunting, increased tone, vigorous suck, and a few sneezes are noted. So my question to the panelists are, is this related to SNRI or lamotrigine exposure in utero? And what are the expected effects or range of effects that can occur in utero exposure to SNRIs, venlafaxine in particular, or lamotrigine? And let me start with Dr. Undisclosed. What are your thoughts?
Thanks, Tim. So first of all, in reference to the question, could it be an SNRI or lamotrigine exposure? I think absolutely SNRI is on the differential. I don't think there was a urine drug screen or anything sent, so there could certainly be other contributing drugs. Certainly opioid withdrawal would be another consideration. And then of course, sepsis. In terms of potential for lamotrigine withdrawal, the literature really is not supportive of that. Lamotrigine is for the most part pretty safe in pregnancy. And there haven't really been any documented cases of significant withdrawal. So my best would be going, first of all, with an SNRI withdrawal. So we would expect to find, with this withdrawal, certainly mild or moderate symptoms of tremor, poor feeding, poor suck. These kids often will get this extensor limb posturing that looks a little bit like seizure. And then certainly more severe symptoms would include like respiratory distress, hypoglycemia. There have been a few documented cases of seizure, though the EEG is usually normal, and encephalopathy.
Very good, thank you. Dr. Wright, could you comment on your thoughts?
Well, definitely getting a good history from mom. I would personally ask her about benzo use, given a history of bipolar. Just benzodiazepine use can be so common and not always picked up on a routine urine toxicology if one was done. In this case, it didn't sound like it was done, but in my experience treating moms with opioid use disorder, the kids with the most severe neonatal abstinence tend to be from use of benzodiazepines. So that would be a thought that I would want to look at. And also, you know, adults that withdraw from venlafaxine or other SNRIs, I mean, it's a rough withdrawal. So I can imagine that the baby would go through the same thing.
Yeah, that's a great comment. I often refer to it as a discontinuation syndrome, but it really is a withdrawal syndrome. Dr. Seligman, can you comment? And I have one other question. It's interesting that Dr. Wright, you brought up benzodiazepines. The question of could we just check the mother's I-stop came up by one of the residents, I think, and you know, there's a particular answer to that. For those of you not in New York State, the I-stop is a prescription monitoring program, the internet system to stop overprescribing, and you know, so that came up. But Dr. Seligman, you can comment and maybe give your response to the resident.
Sure. You know, I have to say I agree with pretty much everything that's already been said. I think in a case like this, you want to consider all of the potential exposures, especially things that may not have been disclosed to you. In terms of the urine drug screening, critical not to, I guess, let me phrase it this way, critical to understand the limitations of what your urine drug screen tests for and the limitations of urine drug screening. I like that Dr. Wright pointed out the issues with benzodiazepines, but I would say it's, you know, beyond that in some opioids, your synthetic opioids aren't really going to show up on your urine drug screen. You're going to get false positives with certain over-the-counter medications. Some of the recreational drugs, the less common drugs, don't come up, like synthetic marijuana isn't easily tested for. So understanding what information you're really going to get out of the urine drug screen. And then I think Dr. Onisko had said something about polypharmacy, and I think that's really important too, which is both the concomitant effects of prescribed medications we know about, as well as concomitant effects with the things that we don't know they're taking, and other lifestyle habits like smoking is pretty common in patients with substance abuse, pretty common in patients with psychiatric diagnoses, and vice versa. So, you know, that's sort of my initial take. I guess looking at the two options, the lamotrigine and the SNRI, I'd probably have to go with the SNRI. There isn't a ton of data out there on the lamotrigine that I'm aware of, but there was a pretty good series of about 83 kids that was described a couple of years ago. Vast majority on monotherapy, which, you know, as we were just talking about the effects of polypharmacy, that's really important to consider. And, you know, they used a Finnegan score to evaluate the behavior patterns of these neonates. So you can get a sense of what behaviors overlap with other drugs that are classically described as having neonatal absence syndrome, like opioids. And from their data, they had about 10 out of the 83 women whose child had a score, but those scores peaked out at less than 4. And none of the kids had it peaked out at a score of less than 7. And none of those kids had a score over 7. And the conclusions from that paper were that there really is not a withdrawal associated with lamotrigine. So while some of these kids may manifest behaviors that are also seen in opioid withdrawal, the low scores were not significant enough to cause a clinically relevant withdrawal syndrome. You know, I think that's also a relevant point, is that withdrawal is pretty common in the general sense, and you have to know whether you're talking about, are we talking about substance withdrawal, or are we talking about treated substance withdrawal? Because a lot of times the population that's really being discussed is treated substance or withdrawal, and that doesn't mean the kid didn't manifest behaviors, it just meant they were mild. You know, and when you look at the SNRIs, knowing that somewhere between 5 to almost 90% of kids are going to have some symptoms of poor adaptation or discontinuation or withdrawal, whatever terminology you want to use, and they overlap with, so far, the description of this child's behaviors, to me, that would be my go-to causation. As far as the use of iStop, you know, I would say that just goes back to the same thing of understanding the limitations. iStop doesn't cover the benzos that the patient took out of their parents' medicine cabinet. It doesn't cover the benzos that they bought in another state, because unfortunately our prescription monitoring programs, to my knowledge, to date, don't communicate with each other between states. So there are a lot of limitations that wouldn't exactly rule out benzodiazepine use, even if the iStop was negative.
Right. Yeah, well, my point about the iStop is we have two different patients. We have the mother, and right now we're involved in caring and consulting for the baby, and that mother had actually been discharged. So to get the consent to look into our iStop, we'd have to actually get consent. And your point about communication with the other states is certainly valid. The New York iStop, I think we're able to look into about 30 some states. Maybe more. Dr. Ramsey had said you can access nearly all 50 states in Puerto Rico through the iStop. It has been increasing through New York's prescription monitoring program, but I don't believe all states are like that. So we're getting closer to a national PMP. So thank you, Dr. Ramsey. Dr. Bashevitz, do you have anything or anything from the chat? Oh, you're muted.
Oh, sorry. So there is a question about would gabapentin lead to a withdrawal symptom in this case?
I think that's a great comment, and several of the panelists have discussed other substances. Certainly exposure to other GABAergic substances in utero can cause a dependence in the newborn, and we will be discussing potential gabapentinoid withdrawal in the second case, but that's an excellent consideration. Again, what other drugs might be present? So let's continue. Next slide, Dia. So continuing with the case, on arrival to the tertiary care center, the baby is initially sleeping, then awakens with increased tone and is jittery and feeding poorly and noted to have undisturbed tremors while sleeping. Clonidine is begun at 0.5 micrograms per kilogram. It's given once. Later that afternoon, the baby's math score is 14 with excessive high-pitched cry, increased muscle tone, tremors when disturbed, loose stools, excoriation to chin from rubbing, sneezing. There's tachypnea. The temps range from 37.2 to 37.5. Repeatedly noted to be jittery and irritable, sleeps very briefly and has tremors, and is feeding but is poorly feeding. Additional clonidine is given. Despite clonidine, the infant is extremely agitated and unable to console despite many comfort measures. Noted to be arching, is pushing off, moderate tremors, tachypnea, and sneezing. After the second dose of clonidine, on day 1, the baby is able to settle down and swaddle. The respiratory rate decreases to 50 breaths a minute and is finally sleeping. Next slide. The following morning, the NAS score has 14. Baby's not sleeping. It's excessive crying, increased respiratory rate, disorganized feeding, and the child has become febrile and is noted to have extreme muscle tone. So the phenobarbital is ordered at 2.5 milligrams per kilogram, and the infant is able to settle 20 minutes after the phenobarb is given. Clonidine is scheduled at 1 microgram per kilogram every 6 hours, and phenobarb is scheduled at 2.5 milligrams per kilogram daily. And this is now at 3.5 days of life. Baby was born early on the 28th, and this is now at 3.5 days of life. You can see some times for the past 24-hour modified Finnegan neonatal NAS score, and ranging from 5 to 12. And during this time, we were able to communicate with the mother and ask about other substances, which she denied. She said simply the lamotrigine, the venlafaxine were her only medications, and she was willing to provide a urine screen, which returned negative. This urine screen did include fentanyl. All of the limitations that Dr. Seligman had brought up, venlafaxine certainly wouldn't show up on this screen, but the baby did not have a screen. Initially, did have a subsequent screen without any identified substances. Again, limitations to the extent of the panel, which were basically the same thing as shown on the screen. Next slide. So at this point, there's some improvement with phenobarbital, but poor feeding and persistently increased tone. There's high-pitched cry, paroxysms of tachypnea among the other symptoms. Is this consistent with Snri discontinuation or withdrawal related in any way? So we've already talked about related in any way to lamotrigine, probably not, but with the severity and persistence, the NICU fellow had thought that this is getting to be a little bit out of the range for symptoms he'd seen in the past. And I'm wondering if panelists can describe the different types of scoring and modifications and how they're used for various neonatal withdrawal syndromes. And I have one example to show after this. So, Dr. Undisclosed.
Well, the one that we use and the one that is most commonly used is the modified Finnegan scale. And it really assesses, scores the baby based on many different things, which include feeding, suck reflex, consolability, and some vital signs every 2 hours. And a score typically of 8 or above is certainly concerning for at least some mild withdrawal.
Dr. Wright, do you have anything to add or comment in addition?
Yeah, I mean, the Finnegan score was developed specifically for opioids, but yes, it has been used a lot for other sort of withdrawal syndromes. My concern is just, how involved was the mom? Was she rooming in? Because there's a lot of evidence to show that rooming in protocols, and there's another screening protocol or for Eat, Sleep, Console. So if mom and baby are able to room in, it sounds like she was transferred to a tertiary care center, and it's hard to say if the NICU, it's a lots of light, lots of noise. Generally, it's a bad place to treat babies who are going through withdrawal. And so if get the protocol so mom and baby are together. I think we'll mention breastfeeding later on, but it can really help in all cases of withdrawal, just the skin to skin, and a lot of cases of neonatal withdrawal are just really maternal withdrawal. So, really encouraging the mom and the baby dyad and realizing that they're not separable at this point.
Yeah, those comments are excellent, and a lot of effort was made to have mother present and involved, and there were some difficulties. They had another child at home, and mother wasn't breastfeeding, but did attempt to swaddle and be present. There were times that the NICU team had difficulty reaching both her and her husband, and the husband was really, when present, in particular during the first day, agitated, confused at times, and seemed to be kind of in distraught. And I think people that led staff and others to have concern for is there something else going on that we're missing, other substances in particular. Although again, mother had consented and seemed to be pretty forthcoming with her history, but there was not the extent of connection and mother to baby protocol that we would have liked. And what about, is this getting beyond SNRI discontinuation withdrawal now, or still consistent? There's been a couple of questions in the chat. What about the sneezing? And people haven't seen that necessarily during SNRI withdrawal. But Dr. Sullivan, do you have anything that you want to add first on the scoring, and then on any of the other questions that have been brought up?
As far as the scoring, I think a lot of the most important points have been hit. The one, I guess I would point out two things or three things, which is that mostly this is a scoring system that was developed for full-term neonates and or late preterm neonates, and so we know that withdrawal does exist in some of our earlier preterm neonates. We know that women with substance use disorders are at risk for preterm birth, and while withdrawal may actually be less in preterm neonates, I think one of the things to consider is it's not exactly clear what the pattern of withdrawal is in a preterm neonate and how that compares to a term neonate, and that some of our preterm neonates may not be able to manifest some of the items on the score. So if you're an intubated neonate, how do you get a score for cry? So there are times when, and I guess this goes into my second point, is you still have to treat the patient. So there are times when the score may not give you the full picture of the infant's behavior at that moment, or the full clinical picture, which may lead you in a slightly different direction. What was the other part of the question that you had asked?
The other part of the question is this getting beyond the point of where you would expect SNRI discontinuation severity to be, and then a question about the sneezing, and is that consistent?
So I guess my take looking at this case is that so often, this seems unusual because so often we get children exposed to, or neonates exposed to SSRIs and SNRIs. I would guess that in our institution, it's probably a good 30% of parturients are on one of these SSRIs and SNRIs, and mostly they don't manifest any significant symptoms, and they go home. And so when we see a kid with more significant symptoms, I think there's a natural inclination to be unfamiliar with it and to question whether it could be something else. But when you look at the data in the literature, this doesn't fall outside of the realm of possibility for SNRI withdrawal with symptoms ranging in duration up to even 21 days. You know, it's a little bit outside of the ordinary, which would be symptoms that resolve usually no later than 14 days. But a kid having 3 weeks of symptoms is not unreported. The other thing about the sneezing, again, you know, it's not a common symptom, but nor is a kid needing pharmacologic treatment for SNRI withdrawal, and sneezing has been reported in cases of more severe SNRI withdrawal symptoms.
Very good. There's been a couple of comments in the chat. Dr. Bishevitz, do you have any that you want to share?
Yeah, I just wanted to say that being a psychiatrist who's using a lot of venlafaxine in adults over the years, certainly the discontinuation syndrome is very varied. And I just wanted to mention that the term that many patients use for this is a very descriptive one. It's brain zaps. So you can only imagine what the neonate is going through if adults are extremely upset about this brain zap phenomenon that they feel. There's also a question in the question area, what criteria warrant adding phenobarb on top of clonidine to address such symptoms in babies with SNRI withdrawal?
What criteria?
Yeah, what made you add phenobarb when you did?
So phenobarbital the decision was made by the NICU before we were involved, and it's a very common adjunctive medication for opioid withdrawal as well as other neonatal abstinence syndrome. Clonidine and phenobarbital are really a non-specific. One's a sympatholytic, the other is a barbiturate, and Dr. Wright, Dr. Undisclosed, Dr. Seligman can comment, but I've seen them used in quite a few different protocols, primarily and adjunctively. Anything to add, Dr. Wright, Dr. Undisclosed?
Yeah, I've seen definitely phenobarb being used as a second-line treatment for opioid withdrawal after, either morphine or methadone. And I think the thought is, just to, again, calm down, some of the other adjunctive symptoms. There's a lot of comments in the chat that about this looking like opioid withdrawal, and somebody brought up the good point that the toxicology didn't look for buprenorphine or methadone, which wouldn't show up on an opioid toxicology, and I'm not sure how extensive your toxicology was. So that's a good point. But I would just wanted to make the point that because the Finnegan score was developed for opioid withdrawal, it's going to look like opioid withdrawal if you use that score,
Right, and that's a good point, Mike. There's a couple of questions in the chat box, but I've heard patients describe the vaccine discontinuation as static electricity in the brain, and like you're getting. So brain zaps is a good way of describing it. Would there be a point, at no point did mother or the father report opioids, but would there be a point that you would consider adding morphine or treating with an opioid in a case like this where symptoms seem to persist despite the phenobarbital and the clonidine? Certainly we have room to escalate the doses, but Dr. Undisclosed?
I would absolutely, if the baby didn't seem like they were responding, I haven't had great luck with clonidine, but certainly if they weren't responding that well to the phenobarb, I think it's very reasonable to give a short-acting opioid to see if, this helps. So I certainly would.
Okay. Interesting. Let's continue so we can get through the second case in time as well, but we've got more to the first case. I just have a couple of slides describing the modified Finnegan neonatal abstinence score. This is just one of 3 parts. You can see the first system, central nervous system, a variety of different signs and symptoms, and score, as well as room for comments. And again, per Dr. Seligman, there may be limitations depending on intubation and other factors. Next slide. The second domain is metabolic, vasomotor, respiratory disturbances, and again, some various signs and symptoms to look for and a range of scores depending on the severity. Next slide. And the final domain is gastrointestinal disturbances, and you have some various signs and symptoms as well, the total score, date, time, and you can track this over time and reference in this modified Finnegan. Next slide. So we were consulted as the baby is still having quite a few symptoms, and this is day of life 4, and I've been involved in a couple of cases planning and baclofen exposure that was planned in a patient that had done her own research, and so that they consulted our toxicology and addiction team, and we looked at the case and looked at the literature as well as Dr. Sullivan found, and really found that SNRI. My initial impression was that this is more severe, but as I looked into the literature, I realized that you can have cases that persist and are this severe, and we advised to increase the dose of clonidine. It seemed to help to 2 micrograms per kilogram per dose, and then increase the frequency if needed, because it just didn't seem to be as frequent and continue. The phenobarb increased to 5 milligrams per kilogram once if the 2.5 twice a day is not controlled sufficiently, and then to resume the 2.5 mg per kg. So they give a little bit of a load. And then alternatively, in one case report, they had used a small dose of venlafaxine, which would be a very hard compounding, well, not complex. If you have a compounding pharmacy, you could compound a milligram of venlafaxine, and that's what was used in the case report as a solution and give to the baby. And that was if the other symptoms weren't working and mother is not able to nurse and breastfeed, because in taking venlafaxine, she would be able to pass them along to the infant. So had a differential diagnosis of SNRI discontinuation. There's some thoughts that there actually cases like this early on may actually be SNRI toxicity, in particular with venlafaxine, as the venlafaxine crosses the placenta and the baby has a longer half-life of elimination of both venlafaxine and its metabolites. I think there's less evidence behind that would improve, I think, a little bit quicker, but that is brought up that maybe we're missing some of the diagnosis as I'm calling it withdrawal when it may be actually toxicity. Certainly withdrawal from other drug exposure in utero, but there's no testing meconium. We had limited information initially about the mother's history other than bipolar affective disorder, and there may have been other medications, but there was no known opioid or sedative use. Again, as I mentioned, the parents have been missing or difficult to contact at times, and then there was a visit by the father where he was labeled and anxious and agitated, ultimately redirected by unit nursing leadership that I think kind of muddied the water a little bit. Next slide. So what are the options, rights, when additional information is needed from the mother in this situation? Can the team request the UDS from the mother if history is not sufficient? Identifying whether or not other substance use, does it matter in this situation? And do we have any other comments based on the recommendations? I think certainly one of our experts would have added morphine, looking at the symptoms, considered that this may be an opioid we just not have picked up. But Dr. Wright, do you have any other thoughts and want to comment on?
Yeah, I think whether or not you have to get consent from mom is definitely state specific legally, but ethically it is absolutely required to get at least verbal consent from mom, and it's what ACOG recommends. Certainly that it would be wonderful if we could only have the UDS be helpful for medical reasons and medical diagnoses, and in this case, extremely helpful. But unfortunately, it's fraught with so many legal and social difficulties and getting child welfare involved. And so women and really need to know the implications of ordering urine toxicology. In this case, it sounds like she was very much on board, but in some cases there are very good reasons why women refuse testing. there's been used racially to, in a very inequitable manner. Black women are performed urine toxicology on much more often than white women, despite similar incidences of substance use disorder, and also reported to child welfare a lot sooner for positive toxicology than white women. So many legal and social implications of this. So unfortunately, if it's just a medical test, that would be wonderful. But because of the war on drugs, it's not. So we need to be mindful of that.
Yeah, very important points. And appreciate that. Dr. Nisko, do you have any comments?
I have to say, Dr. Wright did a brilliant job covering all of that. It is state specific, but I think ethically you need to get the permission from mom to be able to send it. And let's see.
Thank you. Yes, the comments on the racial disparity certainly very critical. Dr. Seligman, you brought up similar things in your previous participation, similar comments in the presentation. Do you want to comment anything additional or other thoughts?
It's been well covered. I can say very quickly, as everybody said, know your state laws and know the legal implications of testing. Your approach really matters. We haven't quite talked about this, but 2 people walking in the room to ask the mom for UBS are not going to have the same results depending on the language they use and how they make the parent feel in terms of their approach. So make sure to use non-stigmatizing language, explaining to the parent something like, this is not punitive, this is to help us take the best care of your neonate, or at least in New York, we're able to say that. And so that's really important. As far as the consent, everybody said it, it's the ethically correct thing to do. You have to know your state specific laws about the form of consent. With the neonate in New York, we don't require consent to my knowledge. Would it really matter at this point? I mean, I guess I'm a little bit outside of my lane, but I kind of feel like not. If you're several days into this, how much is there are limitations to what's still going to be positive on the UDS, especially if use has stopped. And so you might get a false negative because of there no longer being the substance in the urine. Then the question becomes, would hair, if you're really that concerned, would neonatal hair be a better sample? Or, there are a variety of neonatal samples, neonatal urine, neonatal the meconium testing, as well as hair testing. Hair, to my knowledge, is going to carry the substances for a greater period of time than the urine would. And how much is it really going to change anything? I think little, because how many things are actually in a standard UDS, and how many of those have treatments that differ from the treatment plan that we're already thinking of doing or have done? And I think phenobarb was, although not anymore the primary treatment, it was at one time a commonly administered treatment for opioid withdrawal. And so, you've already done that. So if you find opioids, it's not really going to change. The synthetic opioids that aren't in the UDS aren't going to change anything, methadone, buprenorphine, because you've already kind of taken that approach. And the only other thing you could do would be add the morphine, as we've kind of discussed. But you could probably do that based on clinical suspicion. But again, little outside of my lane as an obstetrician on that.
Thank you. Dr. Bashevitz, any other comments or anything from the chat?
There's one in the question area. Can we consider hyperthyroidism and sepsis? Any thoughts about that?
I mean, I
think that's certainly. Go ahead. Yep.
I'm sorry. I was just going to say, we're playing Monday morning quarterback here. So I think, when the baby first presents with all of these, you have to cast a wide differential. So absolutely, those are on the differential. But I mean, this is a diagnosis of exclusion. So though, we do have the information that she is on an SNRI, and we're aware that, babies can have withdrawal with that. But, you know, I think in the beginning, you can't anchor just on that.
Absolutely, yes. And there's certain information that I'm leaving out, some of the labs and some of the other clinical assessments, but that certainly was part of the differential. It wasn't simply that, oh, this is a Snri discontinuation, but a great point to consider as well. But let's move on. We've got another case coming soon, but a baby has been diagnosed with hypocalcemia. Calcium is given in addition to the clonidine and phenobarbital. Day of life, there's myoclonic jerks, tremors, diarrhea is really significant, buttocks are excoriated. The phenobarbital and increased clonidine helped quite a bit, and you can see the modified Finnegan scores dropping from the first to the second, one episode where it reached 10. Next slide. Day of life 8, the phenobarb was continued at 2.5 milligrams per kilogram twice a day. Day of life 8, clonidine 2 microgram per kilogram every 4 hours. Feedings have been challenging, but with heroic efforts by nursing and other consultants and swaddling, the child's doing better. Calcium and phosphorus are replaced. Phenobarb was DC'd on day of life 8. Clonidine continued for 3 days before tapering, and instructed the clonidine taper to occur at 1.5 mics per gig for 4 hours, then spaced out to 6 hours, and just spaced it out every 48 hours. And it was off on day of life 22. And the NAS scores were much, much lower from that 3rd, 4th, and on to the 3 to 5 range, typically during this wean, with the phenobarbital being off on day 8 and the clonidine continuing to 22. Slide 22. Next slide. So again, we've already talked about, is this typical pattern for Snri discontinuation or withdrawal? Would anyone have done anything different? I think we've already covered this a little bit. The mention of morphine potentially earlier to treat. I think if going back, I would have been more aggressive in recommending the trial of venlafaxine, a small dose, to see if that dramatically improved things, and that's probably one of the only things I would have done different. We did consider recommending adding the standard morphine to the protocol, but there was improvement with the phenobarbital. We seem to be on the right track. Any other final comments for this case?
I think the only other thing I would add, and I think Dr. Wright already touched upon this, was that we do know that that venlafaxine does get passed into the breast milk. And I don't know if we talked with mom about possibly breastfeeding the baby, but that may certainly have helped as well. I mean, you know, obviously you want to start with non-pharmaceutical measures, but it sounds like this baby's symptoms escalated pretty quickly. But I think absolutely not only because of the fact that she'll be passing the venlafaxine and its metabolites, its active metabolites, in her breast milk, but also just that bonding, I think, is comforting to the baby. So that would be the other thing I would definitely emphasize. I don't know if she was willing to do that, though.
I know that was encouraged, and she wasn't willing to. And I didn't have a direct interaction with the mother. Our fellow did, and did a really nice job in terms of interaction with the screen, and I think, you know, had a perfect approach to her in terms of, you know, being non-judgmental. This is why we are trying to get some information. So next slide, I just have some summary on venlafaxine in neonatal abstinence syndrome. This is taken from a review of neonatal venlafaxine discontinuation syndrome in the Journal of the European Pediatric Neurology Society, and they described 14 cases with really similar symptoms and lasting until up to day 21, as Dr. Seligman had said. In one of these cases, the child was given a dose of the venlafaxine and had improvement noted. Most were treated with you know, variety of supportive measures, medications, and you can see this reference if you're interested. And again, as mentioned earlier, we did not think the lamotrigine had anything to do with this. Let's move on to the next slide. So again, supportive care with medications, monitoring, using scoring for withdrawal. We talked a little bit about toxicity versus withdrawal or discontinuation. Maternal breastfeeding is important and can make a big difference, and consider dosing venlafaxine if symptoms severe and persist, and consider, despite the supportive medications, and consider alternative causes, sepsis, and other substances. Next slide. Let's move on to case 2. Combined opioid and gabapentinoid withdrawal in a newborn. Next slide. A 27-year-old female with a long history of polydrug dependence, including opioids and stimulants, had been staying in a local YWCA-associated program for women in recovery. She'd been prescribed 8/2 milligram buprenorphine naloxone 3 times a day and been taking that for 6 months, but transitioned to methadone after an episode of endocarditis during the pregnancy, which required hospitalization and prolonged IV antibiotics. Next slide. She was also prescribed gabapentin, 800 3 times a day, although reported taking extra at times, and her other meds include clonidine taken intermittently, hydroxyzine, and escitalopram. After delivery, her baby is scoring much higher than anticipated despite treatment for neonatal abstinence syndrome, and the NICU consults toxicology for evaluation regarding possible other drug, e.g. gabapentin or SSRI withdrawal. Next slide. So the baby is 6 pounds, 9.5 ounce at boy, born to 27-year-old G5P1-2 mother. Mom has an 11-year-old daughter who was born with neonatal abstinence syndrome due to in utero exposure to opioids. She was taking buprenorphine, but as I mentioned, transitioned to methadone during the pregnancy. On day 1, the baby's doing fine. There are no issues with birth APGARs 8, 9 at 1 and 5 minutes. An initial urine screen is negative for tested substances, which doesn't include methadone. This is a very basic screen. There's no fentanyl on it either, or buprenorphine. Next slide. In the evening, 28 hours post-delivery, the baby is noted to have moderate to severe tremors and is hypertonic. Additionally, sneezing repeatedly, there's poor feeding, gagging throughout the feeding, moderate to severe tremors while sleeping, 28 to 32 hours postpartum. Mother is encouraged to pump but declined due to soreness. At 36 hours, the NAS score is 16 at 2100 on the 22nd. And baby is transferred to the NICU for treatment. And you can see the early modified Finnegan scores rising to 16 later that evening, 2100. Next slide. Morphine is started at 0.08 milligram per kilogram at 40 hours of life. The NAS scores are monitored, and the NPASS scores for pain and sedation monitored. The protracted course of treatment ensues, ultimately continues with morphine at 0.08 milligram per kilogram for 4 hours, clonidine 2 microgram per kilogram every 4 hours, and phenobarb 2.5 milligram per kilogram every 12 hours. And this is titrated up over a course of days to get to day 32, yet continues to have hypertonia, extremely high-pitched cry, out of proportion to typical NAS, now 30 days out, started treatment, 32 days of life. So this is actually when we were consulted, and this is beyond what we would expect for NAS. Is there something about the gabapentin or SSRI that we're missing? Do you have other thoughts? Next slide. So here's a summary of some of the course and the dosing of the medication that you can see for review. And again, still the NAS scores are high, 7 to 10, still now at 30 days out. Next slide. So what are your thoughts on this protracted course and treatments? Any comments, Dr. Wright?
Well, I think we covered so many of these in the last case as far as, encouraging breastfeeding with this mom would have been very helpful, kind of antepartum, really working with a lactation consultant to help with that. And then also, the benzos definitely have had case reports of gabapentinoid withdrawal being compounding the effects of opioid withdrawal. So there's definitely things in the literature out there, and just the other points being made previously.
Yeah, thank you. In some studies and just surveillance, up to 30% of patients with opioid use disorder in treatment programs will have undisclosed use of gabapentin, and it's such a highly prescribed medication. whether it's prescribed or just undisclosed. I think very common among all of the other gabapentinoids, which would include pregabalin, baclofen, and then phenibut. It flies under the radar because it's not controlled or doesn't show up in the prescription monitoring program in most states, not in all. In some states, it's starting to be included on the PMP. Dr. Onisko, do you have any other thoughts about this?
Well, I mean, in addition to what Dr. Wright said, I mean, certainly there are a number of documented cases now of suspected gabapentin withdrawal where when they ultimately figured it out and started treating the baby with gabapentin, the symptoms seemed to improve significantly. The other concern with her is that, she has, she's on an opioid as well as the gabapentin. And so, as Dr. Wright said, this can really exacerbate the symptoms, and these babies can develop much more severe withdrawal. There was a cohort study done in 2017 that suggested that the babies exposed to both opioids and gabapentin or other antipsychotics suffered much more severe withdrawal. My other thought was it says she's also on escitalopram. Certainly you have to think about SSRI withdrawal, but the severity of this and the length of this, to me, sounds much more gabanoid.
Thank you. Dr. Seligman, do you have a comments on this?
Yeah, this is similar to a comment I made before, which is that we are so used to, how I said it in the last case was we're so used to not having an issue with neonatal poor adaptation, or at least a clinically significant issue with neonatal poor adaptation, that when the cases don't act per usual, we get a little more alarmed. And this is, I think, a very similar situation where, at least at the University of Rochester, the average experience with opioid withdrawal, I believe, is around 14 days. And as we move towards more modern modes of treatment like Eat, Sleep, Consult, we're seeing even remarkably shorter lengths of withdrawal requiring treatment and hospitalization. But this is not out of the ordinary. When I trained in Jefferson, and that was around the early 2000s, a month of treatment was the norm. So, I look at this and I'm like, well, it's just bad opioid withdrawal. And then the other thing I'll point out is that we have the luxury of seeing so many of our patients moving towards buprenorphine that, we know the literature is pretty clear that buprenorphine has less incidence of withdrawal and lower severity of withdrawal. And so then when you go back to a kid with methadone, at least in New York, we're seeing it less and less that we forget what the methadone withdrawal looks like. But this isn't out of the ordinary. I would point out that methadone dose is not associated with withdrawal. I think that was a big question about 10 years ago. I think the work done by Brian Clearly has absolutely squashed that. Anything over a dose of 40 absolutely has nothing to do with withdrawal. And I would point to some work by Drozdick that what you're seeing when you titrate up in methadone is increased clearance due to the physiology of pregnancy, and you're increasing the dose to maintain a trough level. So a patient who's on 135 who's asymptomatic, and a patient who's on makeup dose 60 who's asymptomatic, they're asymptomatic because their trough level is the same. So the difference in dose is not reflecting the underlying physiology, and that's why dose doesn't make a difference to the neonate.
Dr. Bishevitz, do you have anything you want to add?
Just that I certainly remember that well as well. There'd be, a very prolonged fetal neonatal stays in the hospital over 30 days, even like 40 or more with methadone in the past. Yeah.
Okay, let's go on to the next slide. So to review the case in the literature and prior experience with in utero exposure to baclofen and subsequent neonatal abstinence syndrome, we had recommended adding gabapentin to this at 2.5 milligrams per kilogram twice a day for 48 hours, and then titration by 25% every 4 days is tolerated per scoring, and continue the clonidine taper, but slower than typical. Mother was chronically taking high doses of clonidine as well. And we've already covered this in terms of gabapentinoid or gabapentin use in pregnancy and risk for NAS, and in particular with other opioids, it can increase the risk for withdrawal severity. When I use the term gabapentinoids, I'm talking about drugs that are GABAergic in structure and act in similar ways to gabapentin, or baclofen, and collectively are pregabalin, baclofen, gabapentin, and phenibut, which is a interesting supplement, pharmaceutical from Russia. Next slide. After the first dose of gabapentin, the baby's NAS improved from 11 to 6, and there's mild tremors and really dropped dramatically with the gabapentin addition. There were still some symptoms, but able to feed, and you can see the difference just from the 25th to the 26th, really from variability 5 to 11, and on the 26th, 5 to 9 high score. Next slide. And just again to show some of the case reports of gabapentin withdrawal in the literature, neonatal abstinence syndrome due to gabapentin, and some of the treatments for your reference, which had actually included in the chart to the NICU for the NICU note as well. And these include some protocols that were utilized in terms of replacing gabapentin in addition to the supportive medications, the protocols that they were using for other substances. Next slide. And the last slide is, again, another reference related to in utero gabapentin exposure with opioids, and describes a case and a protocol where methadone with gabapentin was used. Has anyone seen a phenibut case of in utero exposure to phenibut, or want to have maybe a very brief comments on their experience with pregabalin and baclofen? And otherwise, we're very close to time and need to end this in the next minute. Dr. Wright, any final comments? Or
I just wanted to, I wanted to comment that a lot of people use gabapentin for adjunctive pain relief, and about a third of patients with opioid use disorder have chronic pain. One of my patients was describing it the other day that he takes the gabapentin to really help with the pain of withdrawal. So really making sure, to get to Dr. Seligman's point, to really make sure that patients are on an adequate dose of methadone so that they're not going through withdrawal and having to use adjunctive therapies. And this is more of the reasons why we need to change our methadone dispensing so pregnant women can get it at least twice a day, because of the trough being so much more important. We know that split dosing helps with withdrawal in the baby. So just, getting on my political soapbox again, that we need to change laws. But and then just to focus on this article that they, mentioned using gabapentin because it would potentiate the high, but in my experience, patients are using it more to help with the withdrawal symptoms. So really looking at that to destigmatize it.
Yeah, I think it's you have great points, and there are a variety of reasons why patients are using the gabapentin. It is increasingly found when there are fatal overdoses with fentanyl, and seeing the consult service, running the consult service. Once people realize that gabapentin and other GABAergic agents potentiate opioids, there is a natural curiosity to try and see what that feels like. When the treatment is, they get the patient on the right opioid medication for opioid use disorder, and work with them at overdose reduction. But I see a lot of co-prescription without understanding by other providers of what gabapentin is used for in various populations. Any final comments, Dr. Nisco? No.
Not really, other than just to agree with you that I do see a lot of co-prescriptions, but again, a third of these patients with opioid use disorder also have chronic pain, and have found the gabapentin very helpful, but it can potentiate it's definitely abused. No question about that.
I have to say though, there have been many studies looking at back pain with and without radicular symptoms, and much of the literature around the evidence for gabapentin for pain is limited to evidence perioperatively, but not for chronic medical conditions. So it's very, very limited. So I'm skeptical that it's really helping pain, and it may help anxiety and be used as a sedative and other uses, but the evidence for pain is really limited. Dr. Seligman, any final comments?
We've hit on a lot of the important things. There are case reports of withdrawal with gabapentin and baclofen. I'm not aware of any with pregabalin or phenibut. The gabapentin, the main point being look out for it in your opioid using patients because of that 30% rate of patients who are using it illicitly or otherwise. And it makes sense. I think of the cases that are reported of some type of neonatal withdrawal, I would say probably from a data quality standpoint, the jury's still out. When you look at a couple of the really early cases, there's a nice case of neonatal baclofen withdrawal in a mom using gabapentin also. And then there's a nice case of gabapentin withdrawal in a mom who, when you read the details, is using baclofen. So what drug is causing what symptoms and whether, there truly is a withdrawal syndrome. Like I said, I think it makes sense given the overlap with what we know about benzodiazepines and how they also cause withdrawal. So, I suspect it's true. I don't know how well characterized it is. And, definitely something to keep in mind in these more challenging cases. And just the polypharmacies, smoking, SSRIs, SNRIs, benzodiazepines, gabapentinoids, they have all been well established to worsen the severity, the risk of withdrawal, the severity of withdrawal, the length of withdrawal.
Very good. Dr. Bishevitz, any final comments? We're running up to our time here.
No, I think we've covered just about everything.
Okay, thank you. Next slide. This is recorded. The slides will be available, and panelists' emails are included, I think, in the chat if they've made them available. I know Dr. Seligman had. And so I typically end with one final thought. And this is a Late Fragment by Raymond Carver. Late Fragment. And what did you get? And did you get what you wanted from this life? Even so, I did. And what did you want? To call myself beloved, to feel myself beloved on the earth. Thank you all for joining us today. Again, a reminder of the virtual symposium available through ACMT, the Fourth Wave, Methamphetamines and Stimulants. Check this out. It's an outstanding group of speakers. Join us again in April, the first Friday in April, April 2nd at 1 p.m. for the next session. And again, I want to thank our panelists and thank you all for attending. Have a great rest of the Friday.